So is this the last BST didactic, or do you have another from somebody here? Oh, okay. So I think we're bridging to head and neck. Because I know Anna's got some things coming, and then I've got some coming in February. So regardless, I have this set of let me minimize this. This set of unknowns that is sort of bone and soft tissue mesenchymal neoplasms in the head and neck. And I think that, the thing about BST is that it's everywhere, right? Everything is either soft or hard. So you will find these neoplasms in every single anatomic organ system that you encounter, especially in the head and neck. We're lucky because we also have bone, not just soft tissue. So there are 7 cases. What I was hoping that we could do is volunteer to for you guys to just drive the first slide of each of them. If I'm not mistaken, I gave you the one, right? I gave you like the one unknown in the email that I sent out a week or two ago. Does this ring any sort of bells? Yes. Okay, we have one nod. Thank you. So even if you didn't preview, that's fine. But there are 7 cases, each of which has one sort of starter slide and then some immunos and stuff. So I would love it if you guys came up and drove the first slide yourself and just describe it. Even if you can't come up with a differential, that's fine. At least describe what you see, and then we can sort of talk through the differential. So the first case is a soft tissue mass involving the sort of vallecula. So come on down. Thank you. And so what's the vallecula?
It's that structure that's in the midline, and it's like a very on the palate. It's like
you're thinking of the uvula. You're thinking of the uvula that hangs down on the palate. Okay, so what's the vallecula? Not that.
Is it lip oriented?
That's the vermilion border. Okay, all right, we're getting there. We're getting there. Emily. Come over there. I can't hear you.
not totally sure.
Not sure either. Okay, one last chance. Vallecula. Okay, so the vallecula is, all right, so anatomically you have tip of tongue, right? Okay, you have body of tongue. Then in the very back you have the base of tongue, right? And that's where a lot of our HPV cancers occur. All right, how do you get from the tongue to the larynx or the esophagus? So at the very back of the tongue, right, there's a little dip behind the tongue and in front of the epiglottis, right? So the food rolls into that little dip and pushes the epiglottis down to cover the larynx so that the food can then go behind it into the esophagus. So that little dip right between the base of tongue and the front of the epiglottis is the vallecula. And it sort of has like 2 little slopes. So there's like a midline like raphe, and then there are 2 little slopes. So that's the vallecula. It's like that divot behind the tongue in front of the epiglottis, and it lets the food kind of slide into it and roll up and over the epiglottis. Yeah? Does my miming make sense? Okay. So basically back of like oropharynx, essentially back of mouth. Okay, vallecula, go.
So on this slide we have 3 tissue fragments.
Yeah.
That are lined by squamous epithelium. Not keratinized. You can expect it's a region. So I should maybe look at all the epithelium to rule out dysplasia, but this doesn't seem to be the issue.
Yes.
It's a case.
Yeah, that's a good point, right? So anytime you're in a cutaneous or mucosal site, surface dysplasia is certainly something that you should look for because it may or may not affect your interpretation of the underlying lesion. So yes, we don't see really good surface dysplasia here. Okay, good.
Another thing that we can see, this seems to be a polypoid lesion.
Mhm.
It has a base on poly, and then this lesion is also it's not well circumscribed.
Yeah.
So on low power, it looks hypocellular. We have a lot of this pink stroma, and then if we go to higher power, we can see that this polypoid lesion is composed of these fibroblast-like cells. Some of them have like hyperchromatia and large nuclei, like this one. But overall, since it's hypocellular, and so far I just see mitosis. It has some atypia, some mitotypia, but overall it's an issue. Composed of these fibroblast-like cells. Yeah, we abandoned collagenous stroma.
Okay, so we have a polypoid lesion of mild cellularity of spindle cells with background collagen, and some of these spindle cells show this kind of nuclear atypia and enlargement at random. Okay, and you favor benign. So when you favor benign, you know, yes, sometimes we don't have a name for things, right? But we like to. So what would be on your differential? Anybody? So what's the most common sort of fibroblastic, myofibroblastic, quasi-cellular lesion in the oral cavity?
I think it has a name like that, but it's what comes to my mind.
Yeah, so what are these lesions that people get when they like bite their tongues or cheeks or fibroma? So you could consider like a traumatic fibroma, right? So these fibromas in the oral cavity that if you ever sit in on Mark Lingen's service, right, are these benign spindle lesions that have lots of stroma, that have these spindle cells, that sometimes the spindle cells are sort of giant and they can be called quote unquote giant cell fibromas. But is the vallecula a place where you would normally expect like, no, exactly, biting or trauma? Not really. So that's a little bit odd for like a conventional oral bite fibroma. Okay, this is hard, and I think getting the diagnosis on the first slide is going to be extremely challenging, but I want you to put in your mind that there are these isolated cells, right, that have enlargement and hyperchromasia, okay? So go to the second slide, and this is now a second biopsy in this patient a few years later.
Low power, we see this polypoid structure that is lined by a squamous epithelium. Again, the squamous epithelium doesn't seem to be issue here. Also, low power because minor salivary glands. It seems to be minor salivary glands on low power, but now that I'm going to higher power, they are not. So we can see here this looks like plexiform lesion in the sense they're composed by multiple fascicles of, and in those fascicles we can see a mix of stroma, and the cells here have, again, the cells are spindle, mitotypia. There is a mitosis here, what seems to be mitosis, and also has an adipose component.
So now we have similar stromal features, right? Maybe a little bit more myxoid, but certainly these isolated hyperchromatic enlarged cells plus some fat, right? So now how does your perception shift? And you see, yes, what kind of, like a lipoblaст-like cell, right? So in this case, the nucleus is indented by these adipocytic vacuoles, which you would regard as a lipoplast. On the there's another nice one here, like a bi-vacuolated one, right? And then, all right, so how does your perception change?
Now I'm I'm inclined to go to the chapter of adipose.
Okay, great.
Tumors.
Great.
So it's like, so lipoma to me is because of the, it's, but I think about that because of the adipose component, but at the same time, I would like to see more of that carrot, like the collagenous.
Shredded, yeah,
Yeah,
shredded E collagen, okay, so
And
we don't
then-
see that collagen.
yeah,
Mhm.
exactly.
For a spindle cell, I get a spindle cell / pleomorphic lipoma could have some nuclear sort of atypia in it. What should it really probably not have? To appropriately mention. Real lipoblasts, right? So real lipoblasts. And usually the spindle cell and pleomorphic lipomas have these wreath-like giant cells, right? With the nuclei that kind of create this little semicircle or wreath. Have you seen any of those floret or wreath-like giant cells, or mostly these mononuclear individual atypical cells? No.
So that option would be. The location is the thing that I'm struggling with the location because I
Don't
wasn't
worry about the
expecting this,
location.
but
The location is the location. The tumor is still the tumor. So when you,
So-
when your spindle cell pleomorphic lipoma is on your differential, which I think is a good one, what else do you have to consider always, always, always? Liposarcoma, right? Usually what kind of liposarcoma? Usually a low grade well diff, all right? Did you also say myxoid? Okay, so if you pull up that chart that we talked about with liposarcs, right? Myxoid liposarc, yes, has fat and lipoblasts, yes, has curvilinear blood vessels, yes, has myxoid stroma, but what does it not have that this does? Those significantly atypical stromal cells, right? So if you go around and you find even like this guy, right? That's too big for a myxoid liposarc. But myxoid liposarcs usually have small nuclei. They don't have, yeah, that guy, that dark lipoblasts right here, right? That's even too atypical for a myxoid liposarc. Myxoid liposarc doesn't get atypical in this way, right? When it gets atypical, what does it manifest as? The bad part of myxoid becomes round cell, right? Becomes round cell. So you get large round cells with prominent nucleoli. You don't get these atypical annulated hyperchromatic cells. So the type of liposarc that you get the atypical annulated hyperchromatic cells in is the well-diff D-diff spectrum, right? The one that has problems with the genetics in what chromosome or what genes?
has amplification of MDM2.
Okay, right, it has amplification of MDM2 and or CDK4 on chromosome 12, exactly. So these have amplifications of an entire like arm of chromosome 12, and you get these gigantic or these giant chromosome 12s. So if you're thinking about pleomorphic spindle cell, right, you are more gonna think about well-diff liposarc because of that nuclear atypia, right, rather than myxoid, because that usually doesn't have the nuclear atypia. Okay, so what stains are you gonna do for pleomorphic spindle cell lipoma, and what stains are you gonna do for myxoid liposarc? Well-diff liposarc.
Confirm the market spindle, I would go for C34.
Okay.
RB.
Okay.
I know that RB is a bit controversial because it's like.
It's hard to
the staining is
interpret,
hard to interpret,
but retinoblastoma should be lost in spindle cell pleomorphic lipomas, okay? And MDM2, CDK4, all right, so this stain is on the initial, right, that initial biopsy of the vallecula. This is MDM2.
Show me some staining.
Mm-hmm. It's showing some pretty good staining in the stromal spindle cells. Mhm. And there's CDK4. And sometimes we order a third stain, which we've seen on service is P16. Dr. Krause likes this because he thinks that there's some papers out there that say between MDM2, CDK4, and P16, right? If you have two of those three, you have a chromosome 12 problem. So this has all three, so we're pretty good. So, thank you, you can sit. The lesson here is you can get atypical lipomatous tumors / well-diff liposarcs essentially anywhere, and head and neck is one of those sites, and sort of deep oral cavity, oropharynx, larynx is one of those sites. We regard it in the head and neck. I would not call it an atypical lipomatous tumor. I would probably defer to well-diff liposarc because it's such an anatomically complex area, right? Just like the retroperitoneum, that you don't want it to be ignored clinically, right? Oh, it's an atypical lipoma. So this is a well-diff liposarc in the sort of oral cavity larynx area. You can get spinal cell lipomas in the oral cavity. We've seen them, but they shouldn't have this much atypia. They'll be bland, just like spinal cell lipomas in other sites, and you can do retinoblastoma loss. I think CD34 for me for spinal cell lipomas is very hard to interpret because pretty much everything stains with CD34 if it's a fibroblast. So I don't know. I find CD34 more challenging. But morphology, retinoblastoma, and presence or absence then of MDM2 CDK4 can sort of push you in one of those two directions. Okay, does this all make sense? Great. There are out there in the world, if you're on the consult service, you may see places that have in situ hybridization for MDM2, just like we have for HPV and EBER. We don't have that, but that technique is out there. So sometimes instead of IHC, you'll see ISH for the little nuclear speckle. Okay, questions? Who wants number 2? While you volunteer, we can look at the radiology of this lesion attached to the cricoid cartilage that has some white spots in it on this. So, right, what's white? Bone, right? So these are speckled sort of calcifications or ossifications in this lesion that's essentially narrowing the lumen. And this is a case of a patient who would have presented with probably stridor, difficulty breathing, airway problems. All right, and here's the lesion. So here's a biopsy. Who wants it? Be brave.
Okay, wet, low power, that's pretty thick sweaty already. It's like maybe partially encapsulated, at least in one fragment. I guess I should say it is a bunch of it's like fragments. I don't really want to not able to see right now. Oh, nothing sweaty, it's cartilage. Edge of this.
So not normal cartilage, hopefully lesional cartilage. Cool.
Yeah.
Mhm. Yeah, so on biopsy, all of these fragments looked pretty much the same. There's some, I think you're zoning in here on an area of maybe a little bit of increased cellularity, yeah?
Exactly, yeah. Increased cellularity, and it looks like it's kind of, well, I would say invade the capsule, but it definitely looks kind of continuous with the stroma, big stroma of the capsule. Invasion.
Right? So we have a cartilaginous lesion with variable cellularity, maybe some peripheral irregularity, and a normal respiratory epithelium on top. So differential.
Chondroma,
pretty much. So in the larynx, right, cartilaginous neoplasms can be theoretically chondromas, although I've yet to see one. Certainly chondrosarcomas, and we'll talk about chondrosarcomas in the larynx. We always in the head and neck, right, have to think about lesions that have cartilaginous differentiation, right, that are something else. What is probably the most common lesion in the head and neck? Well, two of the most common lesions in the head and neck that have cartilaginous differentiation but are something else. One is benign and one is malignant.
Sarcoma.
So osteosarcoma of the head and neck can have chondroid differentiation. And then what is a salivary gland tumor? What? PA, pleomorphic adenoma, right? So if you're not dealing with a primary cartilaginous neoplasm in the head and neck, you can ask yourself, where am I, right? If I'm in the jaw bones, I could be a chondroblastic osteosarc. If I'm in the salivary gland, I can be a chondroid-rich pleomorphic adenoma. If I'm in the soft tissue, you can get soft tissue chondromas. But if I'm in the larynx, you really, really, really have to think about chondrosarc. Benign cartilaginous neoplasms of the larynx are exceedingly rare to probably non-existent. But the primary treatment modality for all of them is resection, right? Resect, resect, resect with clean margins. So this thing gets resected, and you can go to the next slide. And now tell us what you see.
A little bit different. This, I think what this is still a cartilaginous area, but it looks a lot pinker. This a lot of vessels. And we're starting to, it's like microplasts, maybe. Yeah.
Or at least some kind of vacuolated cells.
Or at least kind of activated cells. Oh, it's
Well, go into the area of increased cellularity on the left, yeah. Does this inform your thought process and what are you seeing here? Is this lesional, non-lesional, worrisome, not worrisome?
It's a worrisome.
Worrisome for sarcoma, worrisome for malignancy. So now we have predominantly well-differentiated cartilaginous neoplasm, right? With these areas of hypercellularity and spindliness. Okay, I'll correct here. Thank you. So in these areas that were unsampled, right? Unsampled on the biopsy, but present on the resection. There's look at that. Nice atypical mitotic figure with these enlarged hyperchromatic E cells in the background, lots of inflammation, fine, but more of these. In the cartilage itself, it still has these sort of zonalities and these areas of clustering. One thing I do want to point out in these cartilaginous areas are these cells that have essentially pinked out nuclei. So what's this? Are these alive or dead? Dead, right? So this is necrosis. This is how cartilage cells die, whether it be benign cartilage or neoplastic cartilage or whatever. These are dead chondrocytes. So there's chondronecrosis in the tumor, which was probably present on the biopsy if we looked hard enough. Yep, right. We have some dead nuclei. So we have chondronecrosis in this cartilaginous neoplasm, and we have a spindle cell lesion in the background with bizarre nuclei, bizarre mitoses, etc. So any thoughts on what we might want to consider this now? Is it benign or malignant? Malignant. Is it chondrosarcoma or not chondrosarcoma? Chondrosarcoma. And what kind of chondrosarcoma is it now? Yes, I know we didn't talk about this in my lecture, because we didn't do bone, but this is dedifferentiated chondrosarcoma. So, and that area that you were pointing out earlier with this, if you were just to look at this is just normal cricoid, right? So this is just normal hyaline cricoid cartilage, right? Compared to tumoral cartilage, compared to high-grade spindle cell pleomorphic area, right? So the way that chondrosarcoma dedifferentiates is it turns into a high-grade malignant spindle cell lesion, right? So, one of the lessons of cartilage in the larynx, right, is it's usually never benign. And just like in the long bones, it can dedifferentiate to a malignant spindle cell high-grade neoplasm. Otherwise, these are generally of sort of low to intermediate grade, and they are resected with negative margins. Theoretically, when any sarcoma gets highest grade, right, this is the highest grade a chondrosarcoma can be is D-diff, then the risk for metastasis increases, right? So then this person might get staging, imaging, et cetera, PET scans, but otherwise resection with margins. Okay, so this is D-diff chondrosarc of the larynx. Great. Genetics are not super specific. In chondrosarcomas of long bones, we've seen IDH1 and 2 mutations, but IDH1 and IDH mutations in cartilaginous neoplasms are present in both benign and malignant things. So it doesn't tell you that it's benign or malignant, but it tells you that it's cartilaginous. You won't find those mutations in, for example, an osteosarc, right? So IDH tells you it's cartilaginous, doesn't tell you benign or malignant. Okay. I don't know what the mutational status of this thing was. Okay, who's next? These are 2 recuts of the same thing. One is the outside consult and one is the in-house. So I'll just maybe leave you with the in-house. And this is mandible.
So at low power, again, a couple different tissue fragments. Seems like a lot of areas of like collagen, pink fibrosis, and then maybe some bone or calcification, I think.
Mm-hmm.
And then over here, maybe a little bit more hypercellular and basophilic. Like spindled, I would say. But there are more rounder. Yeah. It looks like bone to me.
Yeah, looks like bone. There are nice osteocytes in there.
Maybe a lipoblast.
Now everybody's on the eye for the lipoblast.
Yeah, this seems a lot more spindled to me than elsewhere. Vessels.
Go in the area right above this. What are we looking at right now, by the way?
Just like inflammation.
Yeah. So what's in there about the inflammation?
Some areas of like myxomatous change, I would say, and then I don't know, this makes me think of like a varicose body a little bit.
Okay. So there's some palisading of cells around the area, okay.
Some like necrosis.
Mm-hmm. So we have some osseous elements, a lot of inflammation, maybe some necrosis.
This seems different to me than elsewhere.
Mm-hmm.
I don't know what to think.
Okay. All right, so let me take over for 1 second. So, thank you. This is a tough one, right? Because we have a lot of different things going on. We've got spicules of bone, which if you were to sort of classify this, would you call this sort of osteoid, really, really young bone? Would you call this woven, sort of like teenage bone? Or would you call this lamellar, like very mature bone? Seems kind of woveny, right? It's got a pretty organized matrix, but pretty increased cellularity. So probably some kind of woven bone, right? I don't see any lamellae yet. As you pointed out, similar to chondrocytes, right? How does bone die, right? Each of these little individual cells within the lacunae die. So these are pink, right? So this is dead. So this is basically dead woven bone. Not a great sign. And then you have these areas, but I can't really make anything out of the death, right? I can't make a diagnosis on dead anything. So we have to find the live areas. So as you pointed out, there are these spindled areas with some small capillary-like vessels. There are these areas with these organized clusters of cells. These organized clusters of cells have not really well-defined cell borders. They have multiple nuclei. So what are we looking at here? Giant cells, right? So these are histiocytic giant cells. They're not really atypical. The nuclei are open with small nucleoli. They don't have mitoses. They don't have really good hyperchromasia, and they're sort of clustered. All right, so these are foreign body type giant cells. Okay, however, these are different, right? These guys here in this more cellular area have a little bit more atypia, more hyperchromasia, more irregularity in the nuclei, and they are in a background, right? In a background of some bone and some myxoid stroma. So how do we want to consider that this might be in the mandible? Is this lesion or no or non-lesion? Lesion. Okay. Are we concerned about a malignancy or not? We're concerned. What kind of malignancy are we concerned about?
Osteosarcoma.
Osteosarcoma. We're very, very concerned about osteosarcoma. In the jaws, right, osteosarcoma can be osteoblastic, and it can be chondroblastic, or it can be fibroblastic, right? Those are the three variants, morphologic variants of osteosarc that are the sort of main ones. And I find it very, very hard to make anything out of this dead bone, but it's abnormal bone, right? There's some abnormal bone that's happening here. So it makes me concerned that either this is abnormal bone that's being laid down adjacent to some other neoplasm, right? Or it's actually part of the neoplasm. And so when we get to areas like this that have lesional cells, right, in this myxoid matrix with adjacent bone, we are starting to be very, very worried about osteosarc. Ideally, right, you'd want to see osteoid matrix being laid down by the malignant cells. But if you don't, you're going to have to sort of come up with a concerted differential diagnosis and at least suggest the possibility of osteosarc, right? You have a significant amount of woven bone, which makes me significantly worried about osteosarcoma. So, you know, there are a few things you can do. There's not a great definitive diagnostic immunostain for osteosarc because molecularly, they mostly just have P53 mutations and nothing specific on top of that, right? So it's not like, you know, liposarc where it is one manifestation of a specific gene. It's usually just generically P53. Some osteosarcomas have amplification of MDM2, just like liposarcs. Those tend to be of fibroblastic morphology, okay? So fibroblastic osteosarcs. But we've started to sort of throw MDM2 on osseous lesions, just on the rare chance that maybe something is positive and we can call it osteosarc, even if it's not overtly fibroblastic. Well, this is MDM2. And as you can see, the pitfall with MDM2, right, is that it stains these multinucleated histiocyte giant cells, right? There are some nuclei staining in the background, but are those also singular individual histiocytes? Maybe. What about this area here of these significantly atypical cells? I think MDM2 is really, really hard to interpret in here. So I don't really like MDM2 in this context. with the exception of, oh, look, it highlights the histiocytes. However, because we know that P53 is mutated in most osteosarcs, we actually did do P53 on this. And remember, right, to interpret P53 as not wild type, right, it has to be either 100% negative or 100% positive in the lesional cells. If it's wild type, you have a hybrid expression. So one might argue that the vast majority, right, of these cells in the background are negative for P53. And what we have left are probably this thing of histiocytes, which are kind of patchy, and maybe some stromal cells or vessels, right, in the background. But honestly, there's a lot of nothing, right? There's a lot of no. So you could use P53 in these contexts if it's no phenotype or diffusely strongly positive to infer that this has a P53 mutation and therefore could be some kind of sarcoma, in this case probably osteosarc because of that extensive osteoid. So that's how we worked through this case. So we did end up calling this osteosarcoma, okay? But they're in the jaws, they can be really, really challenging because they're not always those high-grade ones that we see in the long bones. They're often of unusual morphology, chondroblastic or fibroblastic. And the diagnosis should always be made in context with the radiology. I think this was a consult case, so I don't have the radiology, but always for bone. I know, did Peter teach you guys at all about bone stuff? No, okay, so let's, help me remember next block, which I guess is next year. I'll do the bone lecture, because it sounds like we didn't get to bone this year, so, okay, cool. Questions? All right. The next case is a sort of larynx vocal cord lesion. There was some redundancy of this person's sort of mucosa and in the larynx, and on PET scan, this area lit up, right? And you can see here's where the vocal cords are coming in. So right at the area of the vocal cords, there's this really hyperactive PET positivity. And so they go in and they scoop some biopsies. Who wants it? Thank you.
On low power, I'm seeing multiple fragments, so like the biopsy specimen. And here there is some mucosal epithelium, and below that there seems to be this intense hypercellular infiltration. And what stands out at low power, there seems to be a lot of this blood. So there are these vessels, and there seems to be this fibroblastic proliferation in the background with a lot of extra resated RBCs. So just looking at this, I think my differentials would be, could this be like a vascular lesion versus a fibroblastic? So a lot of vascular proliferation. So maybe do some stains, like CD31 or earth, and maybe myofibroblast and SMA, but nothing can stain fibroblastic lesions.
So we have a differential diagnosis of vascular, of fibroblastic, myofibroblastic. And with a spindle cell lesion in a mucosal site, what are two things you should always exclude? I know we're in the BST section, but you know, if you were just to see this in a larynx, spindle cell, what do you have to 100% exclude?
Under fibroblastic hair, just
In general, spindle cell morphology in a mucosal site. What is the most common spindle cell lesion in a mucosal site? I know someone said it. Squamous cell carcinoma, right? So spindle cell carcinoma, right? So in a mucosal site, spindle cell lesion, numbers 1 through 8, right, are spindle cell squamous cell carcinoma. Number 9 and 10 are spindle cell melanoma. right? And then beyond that, we have all the mesenchymal neoplasms, right? So investigate the surface, 100% investigate the surface in these cellular spindle cell lesions to make sure you don't have surface dysplasia or carcinoma in situ. And always throw on your keratin, your P63, P40 immunostains, and always throw on your melanoma, S100, SOX10 immunostains, because those are gonna be the top 30 things you're gonna diagnose ever. However, if none of that makes sense, right, then you have to start thinking outside the box, which you've done in terms of your vascular or your fibroblastic, myofibroblastic lesions. So if I tell you that the S100 and the SOX10 are negative, and the SMA is the next slide.
So S100 SOX10, I'm excluding then a melanocyte lesion with an S100 or SOX10.
S100 SOX10 keratins, and then what did you ask for? Endothelial markers, negative. Yeah.
Okay.
Yeah.
So this is SME is positive.
Right now, what's it staining?
It seems to be staining around the West cells.
Okay,
And the background cells are negative here.
okay, wanna check out a different fragment? Right, so yeah, so sorry, S100, SOX10, keratins, P63s, P40s, CD31s, and ERGs are all negative in the lesional cells here.
Kind of highlighting the West cells.
Anything happening in the background?
And some of the background cells are staining kind of like a fiber, and not as well. So it's not a smooth muscle, so maybe a myofibroblastic
Yeah, so
origin.
yeah, I think some of those spindle cells behind the vessels are staining, right? So if we ignore the pericytes around the vessels, there's some kind of wispy stellated staining in the background. How does that inform your differential diagnosis? So sure, we can consider it a possible fibroblastic, myofibroblastic lesion, but there are tons of them. So which one?
Under myofibroblastic lesions.
And if you wanna go back to the H&E, go back to the H&E, that might be helpful.
It has a myxoid background. So myxoid hypoplastic lesions, picking like I know nodular fasciitis can have fibroblastic with a myxoid background
Okay.
sometimes
Okay,
with extravasated RBCs.
great. What other cells are percolating around there?
There's some berries. Besides fibroblasts.
Besides the fibroblasts and the red cells, are there any other cell types?
Not cells. I'm not saying that. Is there some
inflammatory cells, maybe with those smaller, darker nuclei.
so like fibroblasts? But
Does this
Is
look,
that-
oh, go ahead.
sorry, so I was just looking at the cell. This
Looks like a heart. Do these cells look wildly pleomorphic, wildly malignant? Or are they kind of moderate cellularity, yeah, not so bad, right? Like they're not super giant, super pleomorphic. They all kind of have a similar appearance. They all have this myxoid background. There are these extravasated red cells and these arguably inflammatory cells.
That are these, I mean, this is it's kind of
These little vacuoles, yeah, I don't think that's very significant, except for maybe it just happens in these myofibroblasts. Okay, so anybody want to add anything to the differential here?
Is that IMT, right?
So what would you want for that?
Out.
Out. You go to this, yeah. ALK looks like it's doing something in the background cells. And it's looking to be negative, right? It's like negative in the vessels, right? So that's a good sort of negative internal control. And it looks like something's happening in the spindle cells. So it's, yeah, it should stain this, it can
And
stain
membrane.
any compartment of a lesional cell. Whether it be the cytoplasm, the membrane, or the nucleus of many ALK rearranged tumors, right? So thank you, that's them. So I got lucky here, right? So inflammatory myofibroblastic tumors can be seen in anywhere, any visceral organ, any soft tissue site, mucosal sites, bladders, anything. If you don't think about it, you will never make the diagnosis, right? But if you're seeing a myofibroblastic lesion, it could be nodular fasciitis. What does nodular fasciitis have genetically? USP6 gene rearrangements. Is nodular fasciitis common in the larynx? Not really, right? It's usually in sites that can be trauma exposed. In deep mucosal soft tissues, we are more likely dealing with an inflammatory myofibroblastic tumor. And in fact, they're probably more common in the larynx than we had previously thought. If you don't think about it, you're never going to make the diagnosis. So always have it in your background differential. There's one atypical cell. When you're dealing with a spindle cell lesion with some inflammatory cells in the background, right? Myofibroblastic morphology and staining that you can't make to be anything else, right? So these are certainly lesional, right? This is lesional spindle cells. With not just scar, right? These are wispy, kind of stellate, kind of this tissue culture-like appearance in this myxoid background with this really sort of drawn out cytoplasm, right? These are good for lesional myofibroblasts. The problem with ALK is that it doesn't stain 100% of ALK rearranged IMTs, and it certainly won't stain IMTs that are not ALK rearranged, right? So you've got all inflammatory myofibroblastic tumors. Some have ALK fusion, and some with ALK fusion have expressed ALK, right? So you're progressively lower in your ability to diagnose these. If you have no evidence of ALK on IHC, you can do FISH or fusion testing, right? So we confirmed this with fusion. It was TIMP3 ALK fusion. But the partner is less important than the fact that there's ALK period, which confirms diagnosis of IMT. In the absence of ALK fusion, and you've ruled out spindle cell other lesions, you know, you could still consider this to be an IMT that just doesn't have an ALK fusion, because not 100% of them have it. But you have to think about it. And you have to exclude the other spindle cell carcinomas and melanoma.
So in this location, you always rule out spindle cell, like squamous cell.
Yes.
And then melanomas.
Yes. And the spindle cell squamous cells are arguably harder because they often lose 100% of their immunoprofile. They lose keratins, they lose P63s, P40s. So you really, really have to be careful for dysplasia. Because if you see any amount of surface dysplasia, it's an SCC. Generally. Because that is the most common thing. So you sort of are dealing with your pretest probability, right, of a spindle cell lesion, especially if they're, always look at history, right? If they're a smoker, et cetera, et cetera, et cetera. If they're younger, or they're not a smoker, or there's no dysplasia, then you maybe can creep away from SCC. But if they are older, if there is dysplasia, if they are a smoker, even if it's immunonegative, like you're probably dealing with an SCC. Sorry, go ahead, you were gonna say something.
So any amount of surface dysplasia, that's going to be best.
Yes. In my opinion. There are always the rare birds that end up being something potentially different, but those are very, very, very rare. So your best, clinically your best bet is to default to SCC if there's any amount of surface dysplasia. And if you're lucky enough to do molecular, you can't prove that it's anything else, right? We were lucky enough here to prove that it was something else, and we had the morphology and the IHC to support it, right? But these can be sometimes really, really tricky, but just hunt for dysplasia, do levels, do all the things. Sometimes you may or may not even, for melanomas, right? Then you're looking for like melanoma in situ. Usually Melanomas that are primary in mucosal sites more frequently retain their S100 and SOX10 expression. The problem with melanomas that dedifferentiate and lose their expression, normally those are the ones that you'll see metastatic. So mostly the primary melanomas in skin and mucosal sites mostly retain S100 and or SOX10, even if they lose HMB45, melanate, all those things. So mostly you'll be lucky with that. Occasionally, right, we've seen spindle cell melanomas metastasize from like the skin to the parotid lymph nodes. They lose all of their melanoma immunomarkers, except for maybe a hint of S100, and they are question mark like MPNST. Then you have to do genetic sequencing to tell if they have UV signature, right? Or if they have the melanoma specific mutations like BRAF, NRAS, c-KIT, right? Or like UV signature and not the melanoma mutations, just like P53, then you're dealing with like a squamous cell carcinoma probably, right? So it's like, how do you deal? A lot of this ends up coming out in molecular, unfortunately. If you have complete immunoloss, a lot of your answers come in molecular. UV signature, I know now we're outside the mucosal cavity, right? But if we're dealing with skin, UV signature tells you that this is a cutaneous primary, right? Presence of melanoma mutations tells you that it's a spindle cell melanoma, and like absence of those tells you that it's probably a spindle cell swipe.
You just then sign it out like something spindle cell pending glandular.
Or if the patient has a history, then you can use the history stain. I know I kind of went off a tangent here. It's 8:56. I have 3 spindle cell necky thyroidy things. Do you want me to just go over them, or do we want to save this for a next impromptu session? Fill in a hole somewhere.
You don't mind going over it.
Like,
I think
quickly
that's
go over
great,
it? Yeah. So they're all thyroid or thyroid adjacent. This is the cut surface of a thyroid. So when you're taking your pictures, right? Don't ever forget to take the cut surface because it is extraordinarily informative, especially for those of us who don't see the gross with you guys all the time, right? So really fleshy, like really fleshy. If you took this out of a pelvis, I would say, I don't know, it looks like maybe a smooth muscle, like a leiomyo something of the uterus. But no, this is thyroid, really, really fleshy, really like trabeculated, some hemorrhage, okay. So then in the cut surface of the thyroid lesion, we have what appear to be thyroid follicles that are sort of clustered and splayed apart by these background spindle cells. And these background spindle cells are somewhat bland with these elongated nuclei that have very fine chromatin, maybe tiny little baby nucleoli, and then this background collagen. Shout me out some differentials.
Leiomyoma.
What?
Leiomyoma.
Leiomyoma. What else? Does it have the very long sweeping kind of fascicles that intersect at 90-degree angles like a leiomyoma? Not really, right? These are a little bit disorganized or sort of haphazard, one might say. And I don't see those really discrete eosinophilic fascicles like I would for a leiomyoma. I know I'm going through this a little bit fast. You just took a surge path exam.
Something like fibromatosis.
Okay, fibromatosis could be one, right? Because it's pale pink, right? It's not that deeply eosinophilic pink of a smooth muscle tumor. It's more sort of pale pink. So you could think about fibromatosis. What else? Neural. What else? SFT. So all of those are incredibly great differentials. And here's a nice area with some dilated thingies. So just to highlight, just with any epithelial organ, right, you want to make sure that the spindle cells are also not epithelial, right? So we want to do a keratin to show that these are not epithelial. We want to do a PAX8 to show that these are not of thyroid origin, right? Because in an epithelial organ, just like in a mucosal site, your default is to prove that it is not epithelium, right? Then all the things you mentioned, we can move into. The smooth muscle markers are negative. This is CD34. And this is STAT6. So this is an intrathyroidal SFT. It can happen, but you have to think of it. There it is. You can, I'll send you this link so you can look at this all yourself in great detail. Next, intrathyroidal large tumor case. Cut section again, very trabeculated and fasciculated and whorl. Now, the epithelium is slightly different, right? It's got papillary morphology. It's got chromatin clearing. Is this normal thyroid or is this not normal thyroid?
Not normal.
Not normal. What is it? PTC, right? We've got nice elongation, grooves, clearing, overlapping, wrinkling. We have cytoplasm that's abundant and thick. We have very nicely defined cell borders. I find that this is a very good feature of papillary thyroid carcinomas that accentuates these cell borders, right? Which you can see both in the primary site and in the lymph nodes if you're trying to distinguish this from histiocytes in a lymph node, right? Oh, look, found one, right? There's a nice true intracytoplasmic pseudo-inclusion. Membrane, chromatin, membrane, cytoplasm, okay? So PTC, but what's going on in the background with all of this PTC? This is a little more stroma than we expect for a PTC. So to spare you the time, right, we can have the same differential. Could it be spindle cell epithelial problem? Could it be spindle cell mesenchymal problem like smooth muscle, fibroblasts, fibromatosis, fasciitis, whatever? So this is a common, let me rephrase that. This is a known uncommon variant of papillary thyroid carcinoma that has two components. One is this classic PTC that's BRAF mutated, BRAF stain. Two is this spindle cell stroma that has mutations in a different gene in which I'm showing you a surrogate nuclear marker, whereas in the normal epithelium, it stains the membrane. Can anybody guess what marker this is? Normally in the membrane of cells, but abnormally in the nucleus. Beta-catenin. So this is a beta-catenin mutated spindle cell problem in the background of a BRAF mutated PTC. And these long, sweeping, eosinophilic, pink, fasciculated spindle cells that we have already talked about with beta-catenin mutations, what is that? We're kind of working backwards. Fibromatosis, right? So spindle cell, sweeping, eosinophilic fascicles, beta-catenin mutation, fibromatosis. So this is papillary carcinoma with fibromatosis. Sometimes people used to call it fasciitis-like stroma, because it also kind of looks like it could be nodular fasciitis, right? With these like wispy cells, but it's actually beta-catenin, it's actually fibromatosis. So weird variant. If this metastasizes, it's usually only the epithelial component, not the mesenchymal component. So basically, this is kind of regarded as an interdigitating tumor between a PTC and a fibromatosis that have diverging genetics. Super freaking weird. All right, last one. Thyroid. Now, this is a cut section of thyroid and lesion. They don't look to be together, right? There's a plane between the thyroid and the lesion. But again, it's very whorled and dense. And again, on histology, right, there's a plane between the thyroid and the lesion. So they thought this was an intrathyroidal tumor when they took out the lobe and the thing. Turns out it's not. It's just a neck. It's just a neck. It's thyroid adjacent. spindle cells with some wonky atypia. And if you squint, you might be able to see this kind of like, right, this little like whooshy, almost world storiform-ish pattern. And some of these fascicles with this sort of smudgy chromatin. So think through your spindle cell differential again, right? So we're no longer in an epithelial organ, we're adjacent to an epithelial organ. So maybe you can be less worried about something that's a spindle cell carcinoma, but maybe you can be worried about your general spindle cell lesions, right? So muscle, fibroblast, myofibroblast, nerve sheath, right? Your sort of groundwork, right? So you're gonna do all the things. I'll just show you what the stains are for sake of time. So because you're always gonna be smart and throw an S100 or a SOX10 on something, this is your S100. All right, what do you notice though about the S100? Is it diffuse and strong? No, right? There are some areas that are weak to negative, some areas that are strong. What other, so S100 is a marker of what? Schwann cells. What other cells do we have in the nerve sheath?
The perineural cells are EMA positive. Well, C34 that is like stromal cells in the nerve, but
Yeah, CD34, so S100, SOX10 Schwann cells, EMA, perineural cells, CD34 also stains perineural cells, GLUT1 and Claudin-1 also stain perineural cells. So your first choice was EMA, so this is EMA. So you can see that not only does EMA stain the slightly periphery of the lesion, which you might think, oh, is that just a perineural capsule? But it starts to dive into the lesion and it starts to stain these other areas that arguably were the S100 pale areas, right? So if you look here, check out this area and this area, right? And then on here, check out this area and this area, right? So these are the areas that are weak for S100, but picking up EMA. So if you recall our nerve sheath tumor section, what could this be? This is GLUT1. So we have both S100 and EMA and GLUT1. How do we regard these as? Is it a neurofibroma? Does it have the morphology of a neurofibroma? Because we know that neurofibromas can have all elements. Does this look like a conventional neurofibroma with a shredded kerrid collagen? Not really, right? It's got these more world fascicles with this smudgy atypia that you might think of in like an ancient schwannoma, right? So what are we dealing with?
it's hybrid.
It's a hybrid. It's a hybrid schwannoma, S100, perineurioma, EMA, because it does not have neurofibroma morphology, and it does have dual staining for S100 and EMA. Now, we can allow a lot of smudgy nuclear atypia in nerve sheath tumors as long as we don't see significant hypercellularity or mitoses, which we do not have here. So, if you were to call this a benign peripheral nerve sheath tumor, it's got multi-phenotypic differentiation, it could be a neurofibroma, it could be a hybrid, that's fine. It's a benign peripheral nerve sheath tumor. We've learned that these benign peripheral nerve sheath tumors that are hybrid schwannoma perineuromas have fusions or rearrangements of this new gene, VGLL3. So this is VGLL3 fish. So it's break apart, right? So one copy of VGLL3 is together as yellow. The other copy of VGLL3 is broken apart as red and green. So we have VGLL fusion. So this was mostly of interest. We don't need this because we're calling it a benign peripheral nerve sheath tumor, but we did this for academic purposes and it's rearranged. So hybrid schwannoma perineurioma. Again, if you don't think about it, you're never going to make the diagnosis, but I also think that this exists more than we previously thought. Peter and I have had a number of these that have this weird hybrid morphology. The point is BPNST, benign peripheral nerve sheath tumor. Okay, yeah, there are some references for each of the diseases if you want it. So I can send you out this final full PowerPoint or PET presenter, so you can look through all of it. But hopefully that was helpful. Thanks. If you guys have questions, I'll be around.